This week on the BackTable podcast.
I can't wait for the data, right? As a cardiologist, that is obviously my bread and butter, and every cardiologist is neurotic about the data. I'm more excited that more people, more operators feel the same way as us, as I do, as my partners do. And as more and more people start doing it, more and more people are going to want to enroll in trials, get involved with these companies, and start getting real good data, getting more people believing in it, and then eventually, like I said, getting it really looked at, whether it's large randomized trials by excited and quality operators. I can't wait to see how that pans out. That'll really be the game changer. I know it's going to happen, and so that's what I'm really, really excited for.
Hello, everyone, and welcome to BackTable, your source for all things endovascular and more. You can find all of our episodes online on any platform you prefer, like Spotify, Apple Podcasts, or directly through our website, backtable.com.
Now, a quick word from our sponsors.
This episode is sponsored by Imperative Care, a medical technology company elevating care for people suffering from stroke and other devastating vascular diseases. Achieve the ideal balance of power and control in your venous cases with the Symphony Thrombectomy system, the newest addition to the company's vascular portfolio. By moving the clot capture into the palm of your hands, Symphony provides greater procedural control combined with on-demand, continuous aspiration for maximum clot removal. Equipped with two highly flexible catheters and a mechanical assist tool, Symphony delivers consistent, seamless clot removal in one fully integrated solution. To learn more, contact your local sales representative, visit imperativecare.com/vascular for important safety information, and follow Imperative Care Vascular on LinkedIn and Twitter.
Now, back to the show.
I'm Sabeen as your host today, and I'm here with Dr. Adam Raskin, an interventional cardiologist from Mercy Health in Cincinnati, Ohio. Welcome, Adam.
Thanks, Sabeen, for having me. This is a great opportunity, great chance to talk. Like we just sort of said, I've been a big fan of your show. I think this is great to hear what people have to say about all different topics across the country. So again, just wanted to thank you for giving me the chance to talk.
Of course. And like I said, and thanks for taking the time. I mean, I'm excited. We're going to be talking about really pushing the edge of DVT treatment, thrombectomy today, and really interested in hearing your opinion and your approach to this disease. Before that, though, let's kind of hear more about your background. How did you end up in Mercy and everything else?
Sure. An interventional cardiologist. I've been in practice now, which is pretty wild, 10 years, starting this year. I trained on the East Coast, was in private practice for 5 years on the East Coast. And then 4.5 years ago, moved to Cincinnati with my family and then joined a big medical center here, Mercy Heart and Vascular, which is 5 large hospitals. I got a great chance to get into the endovascular space a couple years ago, but I really found a passion for endovascular medicine, critical limb, wounds, arterial ulcers, venous ulcers. I was really fortunate to be involved in the OBL background on the East Coast. So that kind of got me an introduction into veins, and then sort of ran with it here in Cincinnati, run sort of 2 vein offices. And we realize anyone who gets into the space is going to realize rather quickly that it's, one, an undertreated disease. It's under-recognized for sure. And it gives you really a great opportunity to really make a difference. So became a diplomat of the American Board of Vein and Lymphatic Medicine. So that really kind of gives you a nice background on the guidelines and the recommendations for people doing both deep and superficial vein work. And the kind of, once you get into that space, like I said, it's limitless in what you can do. And then, as I'm sure we're going to get into, the technology has skyrocketed with it. Every 6 months, every year, there's another thing that you can do. So it's really amazing what you can offer the disease of endovascular medicine, both arterial and venous.
Yeah. I mean, that landscape has changed. I mean, you and I are both about 10 years out, and it's completely different from what we started with and how we trained and what we have now in our tools. So
absolutely.
It's crazy.
It's unbelievable. Yeah. I mean, yeah.
And it challenges some of the big data that's out there right now of how to treat stuff, so we're definitely going to go into that. Now, so in your practice, are you focused on veins or more anything endovascular peripheral? Do you do a lot of cardiac stuff too, or you're focused on the peripheral space?
Honestly, all the above. I run a cardiac ICU as well, so I'm big into shock, which ties into VTE. When I give talks on pulmonary embolism, especially, we started a PERT program here not too long ago. I teamed up with a vascular surgeon, so cardiology and vascular surgery got together, and we created a PERT program, which we love. We're super excited about. We meet quarterly. We go over data. We go over cases. We're tracking our own data. So then when I talk about PE, when you really get into PE, I mean, that is a big part of it too, is shock, right? I mean, it is right heart failure. So that's got to be a big piece to it. So that's sort of my passion in terms of cardiology. And then a majority of what I do, probably I would say 80 to 90% of my intervention is on the arterial and venous side. So critical limb, deep vein work, and then a good amount of superficial vein work. I mean, I love that side of it too, because venous ulcers are awful. I mean, it's awful. I mean, what it does to people, being a cardiologist, I mean, how many referrals we get for heart failure and their hearts are fine. And then you start doing a whole workup and they have brutal venous disease. And it's just, these patients' lives are forever altered, but then could be forever made better by superficial vein intervention. I mean, it's so rewarding for the people who do it.
Yeah. And I mean, you're totally right. I mean, it's undertreated. You have these patients who are going to wound care clinic and they just have this venous wound for like years. Imagine. And people come to the office, I've had this wound for 3 years. Yeah. And it's just their skin's changed and everything. And you can offer this, treat the superficial veins and they heal so quickly.
Correct.
Life-changing. So
it's interesting. I and listen to other speakers, I kind of encompass that whole sort of package of comprehensive endovascular work, which is, again, very rewarding. I think when I tell people about wound healing all the time, it could be a combination of multiple things. So to be able to treat, whether it's arterial, whether it's venous, whether it's deep or superficial, I think gives people the best chance of getting their wounds healed.
Sure. Absolutely. So, we're gonna focus on deep venous disease today and more so the acute DVT. Now, you said you started your PERT program. Has most of your referrals, I mean, this is relatively recent, so I'm guessing the answer is like, how did you build referrals to be getting acute and then chronic DVT patients that you're treating at the hospital?
A lot of it comes with our PE program. I mean, obviously without saying, majority of PEs wind up having DVTs. So that's one subset of population. Then it was just being very proactive and making things easy for people. So in order to get referrals, I think for anybody, if you make it easier for someone else, they're going to want to send it to you, right? So I give a great example. I met with the division of orthopedics. Hey, what do you do when you get a DVT? And nothing to say anything wrong with an orthopedist, but that's not what they want to do, right? They want to operate. So they'd send a person to the ER. The patient would sit in the ER for 8 hours, finally get their Doppler, if at all, the same day, get a prescription for Eliquis. Hopefully they can get into their internist office. It'd be a whole production. And that was not easy for the patient. It wasn't easy for the referring doctor. Who knows by the time they got it actually maybe treated or not and can start rehabbing. So imagine if I told you, you get a DVT, you call me, I'll get them their ultrasound immediately in my office. I'll get their prescription filled immediately. And if they need an intervention, it will be handled expeditiously. The phone calls just start. So we've started picking the divisions that needed our help, right? So the emergency rooms, obviously anyone after any surgery, right? Orthopedics, OBGYN, we have a big oncology department. How often do you think an oncologist gets a phone call that their patient's legs swollen? Well, now what do you do? I'll take care of it. So it was the fact that we were passionate about it. We knew that there was a huge subset of patients that would benefit from our services. And once we told people that we would take care of it, the referrals exploded.
Yeah, that's super key. I mean, making it easy, is the key. If they have to jump through hoops or even work with old fax papers and things like that, you got to make it easy,
never happen.
And then it'll just come to you.
We got to make 3 phone calls. It's never going to happen. But And it's the good with the bad. You're going to get a lot of phone calls for things that are not require procedures or, super beneficial from something, and maybe you need nothing, but you got to take it all. And if you're willing to do that, you'll get a lot of amazing cases also that will really benefit from your expertise. So you got to be willing to take all the phone calls, but that's a way to build a program. And for us, it's been very, very successful.
Amazing. So, DVT comes in all shapes and forms. You can have like an isolated below the knee DVT, the tiny one. You can have a larger DVT above the knee, or you can have this extensive DVT, from say Maythorn or something, and you're going from iliac all the way down to where your ultrasound can reach, and then you see clot. What's your way of approaching to a patient with a DVT? You gave that example of an ortho calling you and they have a popliteal DVT. What is your kind of way and approach of managing these patients?
Sure. It's a good question. So the first thing that usually we think about is do they have a pulmonary embolism, right? So there's two, I think, very different subsets of patients. Someone who has a PE, if they're getting treated or not, and also has a DVT, to me, is a very different patient that just has a DVT. And then that could be a whole separate set of patients as well. But if you have a pulmonary embolism and you're intervening, you're obviously intervening because there's a right heart issue. So that patient is sick, right? Keep it really simple. That patient's sick. So if they have a concomitant DVT, really, let's just say iliofemoral or femoral, to me, that's a very high-risk patient, because if they go home and have another event, and it's happened to us, what is their pulmonary reserve? What is their RV reserve? That's hard to identify. So unless you're telling me they're going home with perfectly normal right hearts, which a lot of people don't, that is a high-risk patient. So anyone who comes in with an iliofemoral DVT that we've treated their pulmonary embolism, that DVT gets treated. No matter how it looks, how extensive it is, that patient is going home on the same admission with an intervention, because we want to give them every chance of not having another event. And we've had cases where patients will go home, they seem fine, and they did well with their intervention, but then their next thromboembolic event put them in RV failure, put them in shock, right? So that's one set of patients. So that we're very aggressive about. Then let's just say it's an isolated DVT. I think that takes the patient in its entirety, right? What are their risk factors? What was the event that you think happened that caused it in the first place? Is it reversible? Is it idiopathic, right? Is it something where their symptom onset was within the last 48 hours, or was it 3 months ago? How does it look on ultrasound? Is it mobile? Is it adherent to the wall, right? Except if it gets into the cable system, is there any possible suggestion of compression? All these things come into our head. I think we're for sure on the aggressive side. I think any iliofemoral DVT is likely going to get an intervention from us. I think that the data, what little that we have, really shows these patients do benefit in the iliofemoral system for sure. I think the question also comes up, is it occlusive or not? I mean, that's super simple, but if it's occlusive, I think there's almost no question. So we're rather aggressive, I would say, but so many things at least go into our mind. There's so many different options. What is their access site of ability, our access site ability, right? What is their risk for conscious sedation? You have a 450-pound patient, which happens. I mean, that's the state of the world that we're in, right? That, how safe is that patient putting on the table for something that could take, a little bit of time? So there's so many different factors, but an iliofemoral DVT that's symptomatic, and let's just say a low-risk procedure patient who's young, relatively young, active, and is symptomatic, again, whatever that is, that varies for everyone. It could be very different from, I'm not saying phlegmasia. I think that's easy. It's the patient who's obviously. But it's the patient who's got, maybe a little bit of swelling. They can't mobilize like they want to. It's bothering them. They're going to benefit. So that patient gets a procedure from us.
So I'm really interested in this PE population. In our practice, I'll say, like, when we have a patient with a PE that we're intervening on, I mean, usually we focus on getting the PE out, and maybe they have some residual DVT in the femoral vein and popliteal vein, but we don't leave a filter, and we give anticoagulation and we're assuming that that's going to work. But you're right. We've had these instances where patients have had a recurrent pulmonary embolism. Granted, usually it's smaller. But I want to where did you guys come up with this approach? Or is it very common that people are doing additional intervention on the lower extremity after a PE?
I'm sure it's going to vary everywhere. It's going to vary on the operator. It's going to vary on the system. It's going to vary on your comfortability. It's going to vary on your experience. We got aggressive fairly early on, I think for multiple different reasons. When I came out of training, it was lytics, right? That was the option. It was either anticoagulation or it was lytics. How effective were lytics? Maybe not, right? The randomized data is up in the air, right? There were trials that shown lytics years out really didn't show that much of an effect. So, okay, fine. When that's all you had, I could see people, the very good argument. Well, if it's not really effective, then what's the point anyway? Okay, I hear that. But in the last, let's say 3 to 4 years, our ability to treat this with multiple different catheters, whether it's mechanical thrombectomy, aspiration thrombectomy, safely, effectively, thrombus burden from 90% or occlusive to almost zero. When you see it and you experience it, when you see the clot on the back of your table, there's no way, right? You look at this thing, there's no way Eliquis, and I prescribe Eliquis all the time. There is no way Eliquis is getting rid of that when it's already starting to turn white, right? We've seen it. Do you think what's TPA going to do for that? So, and I understand why those trials didn't work. It makes sense, but our ability to extract clot at such large quantities safely, patients, one, when you tell them that they're going to go home, when you can look them in the eye and say safer, for the most part, thrombus free, the look on someone's eye, I mean, they want it done. I mean, patients like, get this thing out of my leg. And we don't just do it just to do it, but we do it when we think it could be safe, effective, and make a difference. And the technology has allowed us to do it. So that's why once we started, just the ball kept rolling, and it makes sense to us if we can do something safely and effectively. And the trials will show it soon, right? That's what it's going to take eventually when we get there. Yeah. We're just way too ahead of the game. But once all the randomized trials show it's going to be effective, which we know it's going to eventually be the standard of care.
Yeah. I mean, right now, the big data set that we have, but it's kind of old, is ATTRACT, right? And ATTRACT didn't really use the devices that we have available now. And so it's hard to use that as a reason to not treat below groin DVT.
Correct. But the one thing I could say is it showed, I think that at least showed, which we all know, making something that was occlusive, less occlusive, patients did get better, right? The post-thrombotic syndrome rates, despite it weren't different, were lower, better, especially in someone who got a catheter-directed therapy. So it just, in my opinion, the wrong therapy, but we're heading in the right direction for sure. And even those patients who got anticoagulation, I mean, their post-thrombotic syndrome rates were really high. I mean, that's so devastating. When people do superficial vein work and they see these legs, if I had these deep veins that are occluded, now they have venous insufficiency and I can't ablate anything because they're living on a saphenous, I'm like, I would have done anything to have seen you 3 years ago and been able to use, the right catheter to get rid of, open up your deep veins, and then we wouldn't be here. But sometimes it's then when you're stuck, you really are stuck, and the morbidity is through the roof.
And they're relatively young too. I mean, I have some patients that are like 40, 50, and I'm like, I have nothing else to offer you. Like I've tried to recanalize their deep veins and try to do something, but that still doesn't offer great benefit to them. So
correct.
What now? The tech has we touched on this. So the tech has improved over the last 5-6 years. I mean, there's a lot on the market now, from small bore devices to agitating devices to large bore. How has the tech shaped your practice? Like, what do you like to use? We can use specific case examples if you want, but like, what do you use, or do you use everything?
I would say we probably use everything. Could be very patient specific. It could be kind of access specific. It could be the location of the clot, right? You have an IVC thrombus. You're not going to use an 8 French catheter. You have something popliteal, distal fem, popliteal. You don't need a 24 French catheter. I mean, it's so variable. You can get phenomenal results based on the choice that you use. So if you know what you're going after ahead of time, you got a good game plan, you can access the popliteal vein safely. So I would say 90+% of our patients, the access point is the popliteal vein. Typically prone, we feel pretty comfortable. Always in the back of our mind, that PE patient, right? A couple days after their event, can they lie prone safely, right? Because if, God forbid, you cause another one, are they going to be in a safe place in terms of their respiratory status? So that's always a big thing in the back of our mind. Are we going to be able to reach? Where are we coming from? I think we have the opportunity now, which is kind of new, as I've been able to use, there's a catheter with imperative care, the Symphony catheter, which I actually been able to go up and over. I used to avoid it like the plague, going up and over in the venous system. I mean, what a disaster. But we've kind of had this ability where we can kind of access the tibial vein on the affected side and then snare a wire up and over. So the patient's on their back and we can access the femoral vein. We could snare a wire and then run a sheath from the contralateral side up and over pretty smoothly. So we can run like a 16 French gore dry seal sheath from, if someone's on their back, from the contralateral common femoral vein up and over, and run a catheter down. The catheter Symphony is really flexible and travels really easily, especially those valves which we're fighting. I mean, if you have the sheath pretty far down, we can get as far down into a tibial vein. I think that's always also the big question, how far do you treat? But if you can get down there and get a result, I think that, the more you can get, the better. So that's kind of a nice option. But coming from the popliteal vein up, I think that popliteal vein can handle pretty large bore catheters. I mean, we can put in a 16, no problem. Put in a 24, bareback, no problem. Depends on obviously the patient size and stuff like that. But the beauty of the vein work is you can be pretty aggressive. That's why I love it. And the risk is not that high. And you could be aggressive. You could be really aggressive. I think one of the things that we're always in the back of our mind sometimes is bigger is better. You can get a lot of thrombus removed. You got to be mindful of blood loss, obviously. I think as the bigger the catheter goes up, that's always an issue. I think we're still learning. We really are. But keep your options open. That's what I would tell anyone. Keep your options open. Try different things. Use all different techniques, because you can get incredible results. You really can.
Yeah. I mean, I think right now with people who are treating VTE and DVT, a lot of people are familiar with the two big players, Inari and Penumbra. But again, you mentioned Symphony and other products that are there. I was really interested in this approach you're talking about, doing the up and over from the contralateral groin. So is that specifically in your PE patients that you bring them back? Like, I'd just love to hear an example of a PE patient you treat and then what you do after with them.
Sure. So let's just say large bore thrombectomy for PE, good result. You have gotten good distal outflow, right, of the pulmonary tree, certain things that we always look for. We are, as a cardiologist, I'm neurotic about pulmonary pressures, the pulmonary systolic pressure, keeping a good eye on the right heart, right? The right heart is a wimp and it scares me to death. But if you've gotten a really good result and that patient has improved in terms of their respiratory status, we feel really comfortable before they go home, typically anywhere between 48 hours, of bringing them back and then doing an iliofemoral intervention. So we'll put them on their belly and get popliteal vein access, clear out as much as we can. I mean, that would be our standard practice for almost all of our PE patients. If you didn't get a good result, it would make me even more nervous sending them home with an iliofemoral DVT, right? That RV is still not what I would like it to see. Makes me even more nervous because, again, the next one, you don't know what it's going to do. So I would say we would be even more aggressive about the DVT if we did not get this amazing PE result. If you did get a great result, the reserve is probably okay. That if they had a small one, might be clinically insignificant. But we don't have great predictors of that. And there's all different ways, I think, to risk stratify people. But that would be pretty standard. Then I guess the question would come up is, if it's more than just iliofemoral, right? Popliteal vein, tibial veins are all occluded, everything, right?
Just like
so
that
you
type
tell
of patient,
me,
exactly.
Yeah, right. You tell me that you're going to clear out their common fem, right? But their inflow is still terrible, right? POPs occluded, tibials are occluded, gash occluded. That patient's going to do okay? I don't know. They might. We don't know. And we don't know because I think we were never at the technology where we could treat it, right? No one's going to give someone a systemic lytic for a tibial vein DVT. And usually, let's just say majority of the time, clinically insignificant, patients will do fine. But I don't know that. And I think once anyone gets into the, really sees vein ulcers, really sees chronic venous insufficiency, could you have done something? Could those tibial veins that are all the deep vein reflux that's brutal that you can't do anything for, the saphenous are 5 seconds of reflux, 8 seconds of reflux. Could you have done something, right? And that's always in the back of my mind. And I love the question, what if we really did clear out the POP and the tibial veins a little bit more effectively and maybe kept those valves still somewhat competent? Maybe they wouldn't be so symptomatic for a devastating morbidity later in life. So, I think we're at the point where we'll give it a shot. We'll try. If someone's young, and again, always in the back of our mind is safety. But if you can, whether it's access a tibial vein, which comes up a lot now. I mean, there's all different procedures that you're going to have to start accessing veins down in the ankle, right? DVA, and when it does DVA work, you're accessing down there. And if you do a lot of superficial vein work, your skills with ultrasound and accessing those veins for a lot of people are growing every day. I think people are getting more experience with it. They're having what would probably take and still can take a very long time. I mean, if you can be a little bit more efficient of accessing the tibial veins, you can come up and you can clear out a posterior tibial vein and you could really open up the popliteal vein. So now imagine an occluded POP that's open on top of the iliofemoral. I find it hard to believe that we won't hopefully one day show that is truly beneficial now that we have the ability to, like I said, come up and over, and I could put a 16-French catheter retrograde into a tibial vein and clear out some clot, or at least tell you that the POP's going to be wide open. I feel that likely makes a difference. And as technology grows and hopefully research grows, and again, we'll get some publications down the line here. I'd find it hard to believe that increasing inflow is going to make a difference. And then imagine if you put a stent, right? I mean, there's nothing. I love it, but I hate it. If I'm putting in an iliac stent, that inflow better be phenomenal. And if the POP's occluded, how's that going to be? It's better be, it better be tight. It better be tight. And there better be phenomenal inflow. And that's not always the case. And then how often do you deal with occluded iliac stents? That is not fun.
Man. And
that
once they occlude, then it's just,
forever. So there's just so many questions. But what's amazing is that we have the ability to do something now, and we can do it safely. Who benefits from it? I'm not sure, but like I said, we try and risk stratify if it's early on, right? Someone who's had it, it's been weeks or months. I don't think there's much utility there. But truly the acute DVT from ankle up, if you could do something, we have the ability to do something now, safely and effectively.
And you kind of described your technique. So you basically get access into the posterior tibial vein on the ipsilateral leg with the DVT, and then the contralateral fem, and you bring your sheath up and over. Are you using multiple devices then to clear out iliac, common fem, femoral, POP, and then posterior tibial?
Correct. So usually the times we've done it, the iliacs are probably okay. It's going to be mostly the femoral system, and then what we'll do is going up and over, I would avoid. That is not easy to do. But if you can get a wire, if you can get an 035 Advantage wire, it's the most common, from the tibial system straight up, then snare it and pull it out, the contralateral common femoral vein, you have a rail, and you have a really good rail. Once you've got that rail, you can run anything up and over. I said, trying to do it on your own without that rail is a headache, and it's just very difficult. It's technically challenging, especially once you're trying to try and fight all those valves. But now I've taken that out of the equation, right? I have a good rail. You can then run a sheath. Typically what we use 99% of the time is we'll take a 16 gore dry seal. We'll then put it up and over the rail, and then we'll run our catheter down. We'll start with a 16. So that'll clear out as much as we can. And the 16 goes pretty far. Then you can then run a smaller catheter within the 16. You can either run an 8. Most of the time, the 8s won't reach through the 16, but again, just use the rail. You can run the 8 up the tibial vein from the ankle. I mean, I think it'll handle it no problem. Most of the tibials can handle an 8 French catheter. So sort of like a above and below, a retrograde and antegrade approach. You can kind of meet in the middle. So run the 16 from retrograde and run the 8 antegrade, and that gives you your best shot. And we can get some really, really phenomenal results. So trying to clear everything out really from the ankle to the iliac.
And you mentioned you're using the Symphytine catheter. Does that come in all these sizes?
Really nice catheter, 16, soon to be 24. The 16 for us is just a really nice combination of everything from IVC to the ankle. So if you can keep it simple, one catheter can kind of do everything in one shot. We've had some really, really nice results. So we've been really happy with it so far. We look forward to even more experience and some research.
What are the things that you like about it? Is it just that it's flexible? Is the suction any different or anything like that?
When I say different, I would say just as powerful as anything else. The suction capability is really high. To me, sometimes what we've seen is a single aspiration. I mean, if you can the more time you're there with any procedure, just the complication risk goes up, right? So if I can tell you I can turn the catheter on and do a single pull and then do a venogram and you're done, that's a pretty easy sell. Again, reduces fluoro time, contrast time, sedation time. Anything reducing procedure time is a benefit not only to the operator, but also to the patient. So we've had some really, really quick results. Sometimes quick is not always what we're looking for, but if it works that fast, to me, that's a no-brainer. So we like the speed of it, the deliverability of it. Whether you need to run it, it comes with a dilator. You can run it up the leg with the dilator. You can run it up without the dilator. We can inject through it, so you can do your venograms with the catheter in place. You can also hook it up. It's a multi-port, but you can hook it up to pressures. You can check pressures if you'd want to. I like being able to take isolated pictures and identify specifically where you're going, right? So you can see exactly where there's residual clot. It's got nice torqueability. It's sort of one-to-one torque, I would say. The tip has got an angle to it, so I can kind of angle where I'm going. So directionality is really nice. So all these little tips and tricks that increase the success of not only getting good flow, but as much to 100% thrombus resolution as you can. It's not always what we're looking for, but the closer you can get, the better. And we've had, like I said, really nice, safe results thus far. So we were really happy.
Yeah. I mean, that's great. I think every iteration, that's what we're seeing. I mean, all companies coming out with catheters, they kind of make each other better, right? Like,
Oh, absolutely.
Good points. You mentioned multi-port. You know, it's nice to have more ports to be able to do pressures or inject, and just a bunch of other features that may seem small, but they all kind of add on and make it, something that you want to use.
It's nice when it's there.
Yeah, it's nice when it's there. It's like you don't know what you have until you have it, right?
Exactly.
How would you say, is it pretty easy the clot comes out, from the tibial? Like, what should you watch out for? I feel like now the veins are getting a little bit smaller, you're going up and over, it's a little bit new territory. Have you noticed any severe spasm or extrav or anything like that, or is it pretty straightforward?
I think the areas that we get into a little bit of trouble is when we don't understand the chronicity. I can't tell you how many times, this symptom started 3 days ago, but if you really spend the time and talk to a patient or a family, they've had symptoms a lot longer. So I can't tell you how many times we take a picture and the collateral system is so extensive, and that's really where you got to be careful. I think the danger is not knowing the anatomy, feeling really comfortable where you are, thinking you're in a true deep vein when you're in a collateral, thinking you're in a true deep vein when you're in a superficial vein. So knowing the anatomy is so, I think, important, especially when you get below the knee, because it could be tricky. It could be really tricky. So feeling really confident on ultrasound that the artery is right there, right? So knowing that you truly are at a deep vein because it's relationship to the artery, right? So being careful, obviously, but knowing that that's what you want to see, right? I think IVUS is your friend. I can't tell you how many times that's bailed us out, or sure, we're not sure, before you start putting 16 French or 8 French or whatever French it is, not where you want to be. I mean, running an IVUS catheter, I think is so critical because it's super easy and safe, and I'll give you the answer. The learning curve is a little steep, but once you start doing it, it's automatic. So that's really helpful. I would recommend always being on the side of caution of using an IVUS catheter. So knowing the anatomy really well. And then commonly, once you get in there and you realize that it's not as much clot as you thought, but it's fibrotic tissue, the veins stenosed. And then the patient doesn't need an aspiration per se, but just even balloon angioplasty, just increasing their flow in any way. So gentle balloons, and you could be aggressive, 4, 6, 8, 10 will get you somewhere. So I think that's such a key piece to it too, is you don't need to get all this clot out. I mean, it's chronic, it's adherent to the wall, it's not going anywhere. I'm not worried about it. But if the veins occluded and you can just reestablish flow with angioplasty, a benefit to me. Like I said, going from occlusive to non-occlusive, that to me is such a big piece of it. So knowing it's okay to be aggressive with balloon angioplasty is also, I think, more than okay, and you'll still really make a big difference. And if you do a pull, a couple pulls, and you're not getting anything out, that's fine. I mean, like I said, you're establishing the diagnosis, you're realizing that this is really chronic, and then said maybe you have other options of what you could do, and then you take a picture and half the collaterals are gone. And that's the best feeling in the world. You take a picture and they have no collaterals. I mean, the collateral system in the veins is wild. I mean, same thing with the arteries, but just how extensive and massive they could be, and they could disappear right in front of your eyes. That patient's going to get better.
How often do you go in and with this up and over approach, and your wire flies up the PT pop, and you're doing your whole thing, and you realize the pop and PT are like chronically occluded? How often does that happen?
I think more than we realize. I mean, usually we're going to know ahead of time. I mean, Doppler is pretty much a standard. We do a good amount of CT venograms also. I mean, that you're not going to see anything low enough. But we really try and get a good idea of what's going on. We get a good idea of the anatomy, especially if the patient's, it's an outpatient or you have some time. This isn't, again, that PE patient. You have a good time to kind of see exactly what's going on. I think it is more common than what we think. And it is by far the most common not treated. But I don't know if it's right or wrong. I don't. I mean, if someone said you're crazy and it doesn't need to be done, I'd have a hard time arguing. But I also know that it can be done. It can be done safer. And it'd be a very different conversation a couple of years from now, that would be automatic and almost, it'd be uncommon not to treat it.
Yeah. I mean, it's eye-opening for me. Like I said, like when I treat PEs, and what we do in our practice is we treat the PE, and obviously if there's iliofemoral stuff, we'll do that. But below the groin, we just kind of say, okay. But it totally makes sense. I mean, you're obviously at a big place and everything well organized. So I'm assuming you've got some data that we're going to be looking forward to seeing in the next couple of years.
Absolutely. So that's important to us, right? I feel one way about it. I'm very passionate about it. My partners are too. We love doing it just because we're really trying to be as comprehensive and the whole scope of what's going on. But I think the real answer is going to be when we can put it on paper and have hard data that shows that there's a benefit. Are the best part, and I would encourage anyone who's involved in a PE program to collect data, have coordinators involved. It's very difficult to do yourself. We have residents who are involved, a lot of prospective data collection, retrospective data review, things that we get together, like I said, quarterly, and see how we're doing, and keeping everyone sort of up to speed and making sure that we're on the same page as a group. And then we feel better about it too, that we're doing the right thing, that everyone's sort of just on the same level of passion and support, making sure these people follow up. I mean, follow-up is so critical. I mean, that could be the smallest thing, and someone disappears and the leg looks terrible years down the line. So making sure that they get phone calls, they get into the office, and that they're being seen by the right people makes a huge difference. It really does.
No, I totally agree. I mean, that's a big part of it, following these patients up, seeing how their leg improves. If it changes and it starts getting worse again, doing a follow-up venogram and improving things, you got to stay on top of it.
Correct. Yeah, just because they went home doesn't mean you can't get something, down the line, right? I mean, like I said, we talked about, I think every day that goes by, it's going to make your procedure a little harder, but that's not a reason not to give someone a chance, right? Good close follow-up. That leg doesn't look right. They're symptomatic. And there's all sorts of scoring systems, whether it's Velada or VCSS or, SEEP classification. There's all these things that you can follow and document well. So, what exactly, how does the leg, we put pictures in the chart. Every leg gets a picture so we could see exactly how the leg is changing. I think that makes a big difference, right? You don't see someone for a couple months. Maybe, yes, no. Patient says, I think it's a little less red, but isn't it? So little things like that go really, really far and really help us whether or not someone would benefit.
Well, what do you think the future holds for venous intervention? I know it's a big question. Like, what makes you excited about the future? I mean, it's almost like we're kind of breaking the tip of the iceberg. Like, what other things are you seeing down the line?
I mean, I can't wait for the data, right? As a cardiologist, that is obviously my bread and butter, and every cardiologist is neurotic about the data, right? Show me a randomized trial. And when they happen, they are game changing. So I think I'm more excited that more people, more operators feel the same way as us, as I do, as my partners do. And as more and more people start doing it, more and more people are going to want to enroll in trials, get involved with these companies, and start getting real good data. I mean, I think that is really what changes guidelines. That's what changes practice. As I go around and talk about whether it's PE or DVT and all the different things that we can do, and other people build PE programs or VTE centers, it's amazing to see other people be successful and then hear other people's stories and then see pictures online of what great results other than the standard of care, but getting more people believing in it. And then eventually, like I said, getting it really looked at, whether it's large randomized trials by people who are going to, by excited and quality operators. I can't wait to see how that pans out, which just takes a while, but
takes time.
That'll really be the game changer. And I know it's going to happen. And so that's what I'm really, really excited for.
That's awesome. I mean, yeah, there's a lot, I think, just as we saw a lot of differences of how we treat disease in the last 5 years, I think the next 5 years, we're going to see so much data, like you're saying. And I think people are going to change the way how they treat. And then there's going to be more devices out and more ways. It's just it's kind of an ever changing. And that's kind of what I like about endovascular therapy too, right? It's like you're learning and changing and new data was coming out. That's just the fun of it.
Absolutely. And it's exploded. Yeah.
Yeah, it's freaking exploded, right?
When I graduated fellowship, nothing of what I'm doing now was even a discussion then. So it's just, it's really wild. We love it. And hopefully more people will join the ride because it's a lot of fun.
Love it. Well, Adam, dude, thanks for coming on, taking the time, sharing your experience and really kind of showing how you can push, more and more work that we can do with VTE. And it's really amazing what you guys are doing at Mercy. So thank you for coming on the show and enlightening all of us.
Thank you for having me. It was a great time. Again, a topic I love talking about. You put on a great show, and I'll look forward to keep listening as the years go on.
Yeah, we'll look forward to having you on again too. Thank you. And
I can't wait. Take care.
If anyone has any questions for Adam, please feel free to reach out to any of us or Tim directly and ask questions. We want to spread the knowledge. So thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabeen Dhand,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social Media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew
and Judy Dela Cruz.
Thanks again for listening.
The Symphony thrombectomy system is intended for the non-surgical removal of fresh, soft emboli and thrombi from blood vessels. Injection, infusion and/or aspiration of contrast media and other fluids into or from a blood vessel intended for use in the peripheral vasculature, and it is not for use in the pulmonary vasculature. Views expressed are those of the speakers and not necessarily those of the sponsor. Certain content in this podcast contains forward-looking statements, and no assurance of future results should be relied upon. Brands and trademarks referenced herein are those of their respective owners or holders.